The general concept of overdiagnosis can have two definitions. The first being the false positives, which is a screening result that incorrectly identifies a lesion as suspicious for cancer. The cause of this might be imaging artifacts or limitations in sensitivity and specificity of the screening tools, or it can be radiologist related, as in the cases of variability in interpreting ambiguous findings. This usually leads to unnecessary anxiety, tests, or procedures. However, it does not involve overtreatment or long-term health consequences. The other definition can be the real diagnosis of cancers that would not have caused symptoms during a patient's lifetime. 15 to 30% of breast cancers detected through screening are overdiagnosed. This often leads to overtreatment for a tumor that would not have progressed. The risk factors of overdiagnosis include age. It's more common in women over 50, where their natural progression of the disease is slower and the risk of indolent cancers is higher. It includes breast density, where dense breasts increase the likelihood of false positives and may obscure malignant lesions. Also, the variability in genetic predisposition might influence screening outcomes and overdiagnosis. The causes include advances in the screening technologies, such as that mammography has become more sensitive. MRI and ultrasound enhanced techniques detect subclinical lesions that might not pose a clinical threat. The tumor biology, as well as the pathological interpretation, where overinterpretation of microcalcifications or small masses can lead to overdiagnosis. Other factors include screening frequency, patient anxiety and demand, defensive medicine, where healthcare providers may opt for extensive testing and treatment to avoid missing a potential diagnosis, biomarkers and genetic testing, as well as health campaigns and awareness. The consequences of overdiagnosis are a physical impact, the surgical interventions, radiation, chemotherapy, and hormonal therapy for cancers that would not have progressed, as well as the increased risk of treatment-related morbidities. There's also the emotional and psychological impact on the patient, as it often leads to anxiety, stress, and depression, as well as the impact on quality of life. And finally, there's the economic burden, where the overdiagnosis contributes to the rising costs of healthcare, and the resources spent on unnecessary treatments could be better allocated to more aggressive cancer care. Breast cancer overdiagnosis can be minimized through the use of advanced imaging modalities that enhance specificity, improve lesion characterization, and reduce unnecessary interventions. I will quickly go through the different modalities that can be used with some case examples. The first is the digital breast tomosynthesis. It creates a three-dimensional reconstruction of breast tissue by taking multiple low-dose X-ray images at different angles. It improves the specificity, it allows better characterizations, and thus leads to fewer unnecessary callbacks. And studies have shown that DPT reduces recall rates by 15 to 30%, especially in dense breast tissue. These are examples of how tomosynthesis helped characterize and delineate the lesions better in two dense breasts. Next, we have the contrast-enhanced mammography, it combines traditional mammography with an intravenous contrast agent to highlight areas of increased blood flow, often indicative of aggressive tumors. It offers a higher specificity, and this can help distinguish aggressive cancers from indolent lesions, such as low-grade DCIS. It's accurate in dense breasts and allows targeted biopsies, thus avoiding unnecessary procedures on benign findings. What we have in contrast mammography are two images, the low energy and the high energy images, which we later subtract to get the recombined image. And these are some cases of what a contrast mammography looks like. In the first case, we have a benign lesion that shows homogeneous enhancement, and this was a papilloma. In the second lesion, an irregular lesions with heterogeneous enhancement, and this was an invasive ductal carcinoma seen in both breasts. And finally, a case of granulomatous mastitis which shows ring enhancement. PEM is a new imaging modality that has higher resolution than PET-CT. It uses an injection of short-lived radioactive sugar into the body to detect metabolically active lesions. It can help the radiologist focus on active lesions and targets metabolically active tumor, reducing detection of indolent lesions. It's also effective in dense breasts and minimizes false positives. The final images of our PEM is a 12-slice tomographic imaging display, as we can see, with similar positions to mammography, the CC and the MLO views. In this case, we have a 64-year-old female with left breast mass lesions, and she has renal impairment. Ultrasound shows, it confirms the malignant nature of the left breast lesions. However, there were several small outer quadrant nodules in the contralateral regions, which posed confusion, especially that they were hypoechoic and irregular on ultrasound. A contrast study was recommended, and PEM was done. It showed no right breast radiotracer uptake, confirming the benign nature of the nodules. And the left breast upper outer quadrant mass showed intense radiotracer uptake. There was also anterior intraductal extension and another tiny lower inner quadrant lesion. The right breast findings were confirmed to be benign, and the left breast was a multicentric IDC. There's also the breast ultrasound and the breast MRI. The breast MRI offers high sensitivity. It can allow us to use risk-based screening and helps in the pre-surgical planning. And finally, the future of imaging is the artificial intelligence and computer-aided detection, which uses algorithms to analyze imaging data to identify suspicious lesions. This helps in reducing subjectivity and thus improves consistency and interpretation, reducing overcalling of benign findings. It allows enhanced specificity and offers a decision support. It helps radiologists to focus on clinically significant abnormalities. However, it should be used as a supplement to radiologists and not a replacement. In this case, we have a 43-year-old female who came for her annual screening. The mammography revealed heterogeneously dense breasts with no suspicious findings. However, AI highlighted area of suspicious lesion in the outer central aspect of the left breast with a 94% risk of malignancy, and the pathology revealed invasive ductal carcinoma. This pie chart shows that 50% of slowly growing cancers that are curable when found on mammography would also be curable when they eventually become clinically apparent. While we have 20% that are rapidly growing cancers that are already incurable even when found on screening mammography. Then 5% of cancers are curable when discovered on mammography, but will become incurable by the time they enlarge enough to be found on the physical exam. And we have 25% that are slow-growing cancers that are curable when found on mammography, but will never become clinically apparent during the patient's lifetime. And hence the dilemma of whether or not the mammography actually helps in identifying breast cancers, but does it actually help in identifying cancers that will be symptomatic or not? What can we do to overcome this? Number one, we can adjust the biopsy thresholds. The ACR recommends that BI-RADS 4 category lesions should be biopsied throughout breast cancer. However, could low-risk findings, such as microcalcifications that may be ductal carcinoma in situ, be tracked with imaging, giving the concept of overall less is more is a good one. We can explore neural imaging-based screening technologies, such as that we talked about earlier, especially tomosynthesis and MRI. That's combined when performed as an abbreviated protocol, appears to rule out malignancy with a negative predictive value of 99.8%. We can investigate the potential of radiomics. We can use imaging biomarkers to track malignancy, especially that DCIS account for 1 in 5 of new cancer diagnoses. But how to pathologically diagnose DCIS remains controversial. Pathological characterization tends to be difficult to reproduce and prone to inter-observer variability. However, technologies such as breast MRI with dynamic contrast enhancement or diffusion-weighted images could help radiologists better assess the lesion's biological features. And finally, we can tailor treatment protocols. In the first case, the patient came presenting with right breast tenderness and hotness, redness and hotness, and edematous changes that are also extending to the right forearm. There was an enlarged right axillary lymph nodes, which she had undergone biopsy from, and it showed no malignancy. On mammography, we can see right breast global asymmetry, and complementary ultrasound confirmed these edematous changes. There were no enlarged axillary lymph nodes, and there was free supra and infraclavicular lymph nodes. MRI was ordered, and it showed right breast edema with enhancing increased skin thickness, but no enhancing masses. And the right axillary lymph node shows increased cortical thickness and perverse hilum, and it was characterized as likely indeterminate. A wedge biopsy was taken from the right breast edema, and the final diagnosis was dermal fibrosis, and it was negative for malignancy. In the second case, the patient came for her annual screening, and what was found was a right breast stationary grouped microcalcifications that had been stationary since 2022. However, biopsy was recommended, and the true-cut biopsy came back as atypical ductal hyperplasia, recommended for lesional excision. The final biopsy was fibrocystic mastopathy, negative for atypia or malignancy. A further VAP biopsy was done. And in this case, we also had a newly developed upper-outer group of punctate microcalcifications, and they were characterized as by RADS4 for better stereotype-guided biopsy. The first biopsy came back as focal ADH for excision or rebiopsy, and the second biopsy came back as local wile excision was performed, and the second biopsy came back as fibroadenosis with focal flat atypia. In this case, we also have left upper outer quadrant multiple groups of microcalcifications. Biopsy was recommended, and the VAP-assisted biopsy came back as fibroadenosis, intraductal papilloma, and focal ADH with calcifications. In the final case, in the right breast, we have global asymmetry with diffuse scattered nodular densities. Ultrasound confirmed that there was heterogeneous sheet-like areas of altered parenchyma and oncogenicity, and MRI was recommended. The left breast, after MRI, shows extensive retroareolar ducts seen extending mainly in the lower breast, with innumerable variable size circumscribed heterogeneously enhancing solid mass lesions. There were the time signal intensity curves came back as type 2. Biopsy was done, and the results were intraductal papilloma with closing adenosis and focal ADH and no malignancy. There's a current debate that breast imagers are a major problem or a major contributor to the problem of overdiagnosis. However, the counterback argument could be that finding a malignancy at screening doesn't necessarily affect the patient. It's the subsequent intervention and treatment that do. That's why we have to weigh in that even though there could be false positives and overdiagnoses found by mammography, mammography still reduces the mortality, cancer-related mortality by 20%, and less aggressive treatment of cancers found on screening, because less aggressive treatment can be given to patients when cancers are found on screening because they are smaller, less likely to metastasize to lymph nodes, and more likely to be effectively treated. The goal is just not early detection, but the right detection. So to sum up, what can we do? We should weigh the early detection versus the harm. The ongoing research focuses on striking the right balance between early detection and avoiding unnecessary treatments. We should make use of AI and machine learning. We should have personalized algorithms that incorporate genetic, clinical, and imaging data to create personalized screening and treatment plans. And we should optimize the screening intervals so that it's based on evidence of cancer progression, age, and individual risk factors. Perhaps a more constructive approach is to frame the discussion not in terms of overdiagnosis, but of overtreatment. The solution is not less diagnosis, but better treatment decision tools and more information about how to discern life-threatening tumors that will need aggressive treatment from non-life-threatening cancers that can be treated less aggressively. There's no such thing as overdiagnosis, there's only correct, partially correct, or incorrect diagnosis. If abnormal findings are diagnosed correctly, there's only optimally managed, suboptimally managed, mismanaged, and possibly overtreated disease. Overtreatment must be addressed by medicine and society as a whole. Thank you.
Thank you, Professor Sherihan.